Hello, and thank you for joining us. My name is Monica Davis. This presentation addresses the challenge of skin tears in the acute care setting. The PowerPoint slides for this presentation are available on the website of the Pennsylvania Patient Safety Authority, which is responsible for the Patient Safety Reporting System. Let us begin with patient risk factors. The literature identifies advanced age, sensory loss, compromised nutrition, history of previous skin tear, along with cognitive impairment, dependency on others for activities of daily living, bruising, poor locomotion, and polypharmacy. This means multiple medications for various conditions and in combination with the use of an assistive device. Knowledge of these characteristics is important in the initial patient risk assessment for skin tears. What other information is available? Consider which body part is at greatest risk of a skin tear. The upper extremities were mentioned in the PACERS data more frequently than any other body part, and this is consistent with the literature for the greatest risk of a skin tear. Both the forearm and hand are frequently mentioned. The lower extremities are also at risk of skin tear, as are the head, face, and neck, which are most often injured when securing endotracheal tubes. So far, we've looked at skin tear risk related to patient characteristics and body part. Equipment and procedures also have associated risks. The hospital bed is implicated in skin tears in the PACERS database more than any other equipment or furnishing, followed by chair and wheelchair. Intravenous catheters are mentioned more than any other tube or drain, with radiographic procedures following. The activities likely to contribute to a skin tear injury are patient transfers and positioning. Proper lifting, turning, positioning, and transferring techniques can prevent skin tears. Dressing changes and procedures involving removal of tape were also frequently cited. Now let's consider preventative measures. The following measures will help minimize the risk of a skin tear. Manage the patient's environment by reducing friction and shearing and using a draw sheet. When possible, pad bed rails and equipment edges. Choose the right products for your patient. For instance, use foam or paper tape and skin prep. Be sure to use an adhesive remover and roll off the tape. Never rip or pull tape off. And be sure that all are educated to skin tear prevention, including staff, patients, and families. When a skin tear occurs, are you prepared to assess and manage this injury? Since skin tears vary in size, location, depth of injury, and amount of tissue loss, a common uniform language is needed to describe the injury, to document the assessment and management of the wound, and to be able to track the wound changes. There are 3 categories with graduated injury up to a total loss of tissue. There are 2 types of Category 1 injury where there is no tissue loss or minimal loss. The flap type injury where the replaced flap closes the tear to within an approximation of 1 millimeter of the wound edges, or the linear injury where edges come together and close completely. Category 2, or partial tissue loss, is when there is scant loss of 25% or less. Moderate or large when the tissue loss is more than 25%, but not a complete loss of tissue. Category 3 skin tear is the most severe, with complete tissue loss or no epidermal flap covering the injury. Now for the treatment of skin tears. Managing a new skin tear. Position the patient for comfort during the assessment and intervention. Prepare your supplies to clean and dress the wound and preserve the flap if existing. Be supportive of the patient. Skin tears hurt. Start carefully and gently cleaning the wound with saline. Let the wound air dry or pat dry. Often, as in this picture, the flap skin curls or rolls up. When a flap exists, consider using a moistened cotton-tipped applicator to gently unfold the tissue to approximate the edges. Once the flap is uncurled, the tissue should granulate together if protected from disruption or further injury. Apply a non-adherent dressing as shown here, or a petroleum-based ointment and steri-strips can be used. Follow the protocol as recommended by your facility skin care team, as availability of products varies from one institution to another. There is limited research on skin tear treatment, but 2 recent small studies reported in the literature are encouraging in innovative treatments that are cost-effective, efficient, reduce both the pain associated with dressing changes and the healing time. One product is Mepitel, which was shown on the previous slide. It is a soft, silicone-coated net dressing that adheres to the flap skin and tissue and is covered with an absorbent dressing. Another exciting product is a topical bandage called 2-OTB, which dries to a clear film. A secondary dressing is not needed. Remember, the best solution to this ongoing skincare challenge is prevention. The references are as listed, and the photographs are provided courtesy of Franz Millionaire and the Journal of Wound Care. Thank you for joining us for this presentation. We hope you'll find this information useful when delivering patient care. The presentation was based on the article, Skin Tears, the Clinical Challenge. This article and other patient safety related topics can be found on the Patient Safety Authority website as listed here.